Thanks so much, Peter, for those particularly lucid thoughts, even when you're so unwell. I mean, I think key points were really to look at people's interests and incentives. One, in understanding that some of the cycle of panic and neglect is something you should expect, given the way the psychology operates under these sort of, as you said, low probability but high impact threats. But also the need really to relate to people's specific interests and the specific impacts that they have, and to consider the broad realities of people's lives, whether we do that at the global level in terms of thinking as the SDGs as a unifying framework, or at the individual level of thinking, well, what health threats do people really worry about? And I think that particular issue, I mean, in 2013, 40,000 children died under the age of 5 in Sierra Leone, and no one seemed to think that was a global health emergency. And then when there is an outbreak which people feel affects this global risk, suddenly saying, well, that's the priority. And we've seen that challenge and ways to deal with that in addressing outbreaks, including during Ebola, but particularly in polio. So we've had a very sort of cogent set of interventions, and thanks to colleagues for keeping to the time. So we now have a very significant chunk of time for discussion. I think a few key points that have come up firstly that there's a reason that it's hard to escape this cycle, because in many ways the framing of the issue, the way people understand the issue, lends itself to this natural cycle. That's why it's so hard to escape. And whether we understand enough the right brain response, whether we publicize the stories and the individual impacts, is a challenge. And by doing that, perhaps we can improve. We're often much better at communicating broad evidence that can seem a little bit sterile to people, or it doesn't really touch their individual lives. At the same time, it's really important to use the crises to build institutions, and that has been done successfully in some cases and less in others. So it is striking, as Julie said, in the mid-2000s there was this real atmosphere. I remember the New Zealand Ministry of Health, we got all 68 government agencies to talk about the pandemic plan, including the Inland Revenue Service, which was the tax department, which never came to any meeting. I mean, if you had a meeting on the National Diabetes Strategy, you were lucky if you got 3 or 4 agencies. So there was this sort of groundswell, and yet we've struggled to maintain that, even in the impact of further outbreaks. Getting people to participate, though, focuses attention. So if people go through exercises, if they participate, if they get a sense of what are the individual impacts, or if they themselves, as Peter said, feel these impacts themselves in their core business, that builds an incentive for people to continue to focus. So participation is important, and that means we need to find ways for decision makers to think about this when there aren't 10 articles a day in the New York Times as there were during Ebola. Because decision makers, policy makers are influenced by what's put before them, by what is the popular conversation. We also need to bridge this work with other concerns in health and in other sectors. Global health is often encouraged what one of my mentors calls the single issue fundamentalists, or the SIFs. Often the way to success in global health is you define your issue, you raise money for your issue, you build empires for your issue. And that's been a sort of successful way of working. And yet, if you cannot, people beyond our sort of world are thinking of the broader context. So if you cannot link pandemic preparedness to addressing threats like malaria, or addressing issues where people can't get care for diabetes or cardiovascular disease, or people's concerns about their personal security in conflict areas, it makes you less credible. And the economic arguments, I think, I'm glad that Peter highlighted that we do have these ad hoc, we haven't institutionalized economic assessments. So whilst the investment cases are very useful, in many ways we have an investment case for everything in global health. So everybody says, well, if you invest $1 in this, you'll get $4,352 in return using this model which has 1 million assumptions. And it's very difficult for policymakers to bring those together. There's very rarely a sense of relative prioritization, or the trade-offs that are involved in investing $1 in this compared to $1 in that. And I think just also then finally, and Suzette highlighted, that we have heterogeneous and diverse communities. So one size does not fit all. And as always, if we're going to be equitable, we need to not treat everyone equally, but pay more attention to those who are worse off, who have higher levels of risk, and who often miss out from government and interventions from the private sector. We also need to recognise the heterogeneity of our societies. And often this is a very government enterprise, which doesn't reflect sufficiently the inputs of communities or of the private sector, which has many sort of resources and capacities to contribute. So I think we've set the scene very well. As we move into the discussion, maybe I'll just ask one question to the panel to answer briefly. Suri yesterday said, well, we should just accept this. Maybe I'm misquoting her, but that this cycle is inevitable, that there is going to be lower priority and higher priority. And so given that all of you have just acknowledged that we continue to have the cycle in boom and bust, maybe I'll just ask, do you really believe, we've highlighted some of the possible tools, that there are possibilities to transcend this, and this could just become daily mainstream business that engages all of society? Julie, do you like to start?
Well, yeah, I really appreciated Peter's economic insights, and I have to really think a lot about that heuristic. But I do not actually think these are low probability events. They are increasingly probable events. It's just that we don't know where they're going to occur. But from at least my point of view, these things are happening all the time. And so I think of it more in a national defense model than I do in a probabilistic model, meaning that we have no problem investing in what we need to defend our nation against a war. And I think even the poorest countries in the world seem to find resources to be able to think about that and sustain an investment there. So we need to somehow get that mentality applied to the war that we're fighting against our microbial enemies in the same way that we think about fighting against our human enemies. So I think it is possible, but it takes a different mentality or different approach.
I attended the meeting that Peter Sands actually chaired as one of the 5 or 6 blue ribbon commissions after the lessons learned from Ebola and how we should do things differently. And it was keynoted by Larry Summers, former Secretary of the Treasury, who said that between now and, say, 2050, the damage to the U.S. economy and the world economy and other threats to the world, the order of magnitude of that damage from terrorism, from climate change, and from outbreaks and pandemics are about the same. And that we, the U.S., are spending $1 trillion a year on terrorism. We've pledged $1 trillion. I hope we can keep that commitment on climate change. And we're spending tens of millions on preparedness and response to outbreaks. And that thinking of it in those terms means that we really can't just accept the reality that this is the way things are, because we're not doing that, or at least we shouldn't. I think most informed observers would say we shouldn't take that approach to terrorism or to climate change as being episodic. These are systemic problems, and this is the same. I guess this same thing maybe we've underappreciated, and I should have emphasized even more in my talk. KG and I lived through a very painful WHO reform exercise in 2015, in which we passed a 74-paragraph resolution of member states. All of you weren't there because it's a member state organization, but it's very important in WHO, and I don't think people recognize how successful that's been. I mean, I think WHO really did approach Zika and then the Ebola outbreaks in the Congo in a much different and more coherent way, and maybe one of the most important unrecognized aspects of that is that there are standing agreements now with surge capacity, with other actors with whom WHO did not have the same kind of organic working relationship. Now those are in place. And the most important one, from my point of view at least, is with CDC. But because of the security situation in the Congo, we have had, as Suzette talked about and Peter, a risk avoidance mentality, not a risk management mentality. There are plenty of health professionals from CDC and from other U.S. government agencies willing to go into Eastern Congo. We've made a security decision that they're not allowed to do that. And this is self-defeating. It's certainly not in the overall balance of interest, but we're letting this risk avoidance, which actually undermine this formula that we, the U.S., had been instrumental in setting up for WHO in how we as a global community can reach this and what can reach people in need and how the U.S. could support that.
Yeah, I would just add, I agree with my fellow panelists. I don't think this is something that we can just accept. But, this is really hard. And we are seeing outbreaks, pretty severe ones, more frequently than what we've seen in the past. I think, going back to one of the other points that Julie made about this idea of exercising and utilizing those exercises to bring about education, to bring about understanding, and to help improve preparedness efforts and how we would respond to outbreaks is another critical intervention. But I think even where I've seen exercises, I think where we are falling short is that once the exercise is over, we don't talk about it anymore. I think about my city, 2.7 million people, a very outspoken electorate, if you will, particularly with our mayor, who is very closely connected to the business community and the healthcare community. And if those business leaders were talking to him about the possible impacts of a pandemic on their businesses, I think it would compel him to listen a little more carefully and pay a little bit more attention. So I think in terms of how we approach this issue, where we can employ sort of a top-down approach, meaning get top-level leaders and officials engaged, we also have to do the same from a bottom-up approach and get community members and faith-based leaders and other stakeholders engaged as well. And, perhaps it's a bit naive to think that we might meet somewhere in the middle, but, when President Obama passed PPD 8 and promoted this idea of the whole of community approach to preparedness, not many people paid very much attention to that, except for those of us who had to because of federal regulations and funding requirements and things of that sort. And I would say that today, no one's really promoting the whole of community approach to preparedness. But this type of issue requires a whole of community approach. It takes all of us.
Peter?
Yeah, just 3 points. First, Julie's point about the frequency of these things, they're not as low risk as people think they are. Completely agree. We need to be getting out the message that if anything, the trend is up on these outbreaks, which I don't think actually is commonly understood. And in a way, the sort of anniversary of the 2018 epidemic has sort of played the wrong way here because it makes people think that it's a sort of 100-year event. Second, I think we need to be reinforcing the point that although we are getting better at dealing with the morbidity and mortality impact of infectious disease outbreaks, although we can never be complacent, in fact, the world appears to be getting more and more vulnerable to the economic impact. Because we're in such an interconnected world, both in terms of communications and supply chains, the knock-on impacts of things that happen a very long way away can be remarkably quick and powerful. A third point is, I think we need to get much better, and this is where it comes back to the sort of taking a holistic capacity building approach at saying, okay, so how can we get the 48 component parts that come into a JEE and build them in a way that delivers on near-term health objectives in a particular community, so that A, there's a justification and a logic for doing it now in that community because you're solving an immediate problem. But B, also, it's a better solution because that muscle, that capacity gets used and tested. It isn't just something that is there for a rainy day, which inevitably is less resilient and less useful. I also think it's the way you build trust with communities. This is a point that Julie has made and Suzette has made a couple of times. If you are solving an immediate health problem for a community, working with them, then when you need to work with them on something that comes out of left field, you're in a very different position than if you have just kind of arrived with a set of messages. The credibility of the people on the front line, the credibility of the authorities is very, very different. And so I think we could be a lot smarter, certainly in the poorer, more vulnerable places where I focus most of my attention, in how we integrate the health security capabilities with the things that deliver on immediate health needs.
Great. So I think our panelists have basically said, no, we shouldn't accept this. We just need to make the case better. And there are some directions that we could pursue. So we now open it up to the other participants. And I'll try to sort of notice either lift up your name card or put your hand up. And we'll go around and take a few round comments and questions and then come back to the panel. So, Peter, would you like to kick us off? And please speak into the microphone. So
thanks very much.
Peter
Dashett from the Forum on Microbial Threats. Absolutely fantastic discussion. And, you know, we all know about this cycle. And, you know, Peter Sands frames it very nicely in economic terms as almost a problem that's it's against our human nature to deal with. So I wondered if we have examples of how it has been dealt with well, either for infectious diseases or for other cyclical issues of threat. And can we learn from that? And one thing that Surrey Moon said yesterday, which I thought was quite interesting, a way around this problem might be during the crisis or at the peak of the crisis to institutionalize a strategy that then lasts for that trough. And we've actually done that through a series of events, almost with George Bush's $1.2 billion for select agents following anthrax, with President Obama's money for Ebola. It lasts. We know that it's probably unlikely to be renewed, but there seems to be a strategy to deal with the trough. So are there other examples of this? Is that the way we're going to actually get through this?
Yeah, this is Bruce Gellum from the Sabin Institute. This is for Peter. Just the question of a word that hasn't come up is insurance, and the degree to, and we can buy flood insurance and fire insurance and earthquake insurance, or if we think we're going to need it. And I guess the question is there an insurance frame that we should be putting on this? And maybe some of those investments into insurance can also help to mitigate the downstream risk, so the payout is less.
Yeah, well, thank you. That was a great panel and actually very thoughtful comments, and brought to mind that dichotomy that we always struggle with between preparing for pandemics and outbreak threats and investing in being prepared and exercising, as Julie said and others, and then the investment in the day-to-day threats, actual threats, as Peter said, that occur everywhere, communities, infectious diseases. Here in the US, we see them, the foodborne outbreaks, you know, throw away your romaine lettuce over Thanksgiving. Like Dr. Moussaka told us, you know, in Liberia, all of the 30-some small outbreaks that they were able to address post-Ebola because of the resources that built capacity there for, you know, through GHSA. So I, you know, it's fascinating, the attention that the big pandemics get, even though short-lived, and resources that come to deal with them, and they're short-lived. And then somehow, as you pointed out, they don't translate into this realization that the everyday, the day-to-day work that gets us to do the day-to-day is really what is the what we build on, what we surge on to address pandemics, right? And yesterday the discussion talked about seasonal flu, whether it's a question of vaccines, surveillance, monitoring, and how that helps as well in the pandemic. And I'm not saying that we don't need the extra exercising and preparedness. And so I guess a question is, well, how do we, it is a dichotomy, but it's not. It's actually, how do we make it to be part of a continuum here and you know, convinced that it is that day-to-day investment in being, you know, better, you know, safer, that is important so that we can surge and do pandemics, because we don't know. We know that they're going to come. We don't know which one. We don't know where. What can we do to bring it together and make that point that it is really a continuum, and it's We see it again and again. The attention wanes. We go into, what is it, psychologically, they kind of like, optimistics and everything is fine. But it's not, because we experience it every day. Anyway.
Sorry, it's a little difficult to do it from here. Hi, Carolyn Reynolds from PATH. So all of you talked about the things that we need to do. We need, Julie, the irritation that is persistent, right? We need that energy and commitment. Jimmy, you talked about the fact that we need to present the data and evidence in a way that will convince political leaders to act. Suzette, you talked about the need for continuing education. And Peter, you talked about the fact that you have to connect it to people's own personal and political interests. That is a political strategy that is sustained over time. In the same way, so this conversation, every conversation I'm in about this always comes back to this question of political will, but it's the thing we don't invest in. So, we're not investing overall in, the things that we need to do in preparedness, but if we don't, at the same time, if we don't invest in the movement of civil society, of multi-stakeholders in every single country, we're not going to move the agenda. We're seeing the fruition of that a little bit here in the United States. So over the last 2 years, we have begun to build a coalition that has actually engaged Capitol Hill and engaged the administration, engaged the Security Committee and political leaders. It's nascent, but it's beginning to show fruition by pulling those pieces together, by making the cogent political argument and actually making it an issue of interest that will convince political leaders to act. But we're not seeing funders actually recognize the importance of that. So I would love your thoughts on that.
Yes, thank you. Rafael Obregon, UNICEF. I have a question for Peter, specifically on your point about how to better integrate the health security capabilities into the broader health agenda. And I wonder if you could elaborate a little more on this point, and what would be some of the practical entry points to make this happen. As we look at the current context, for instance, the donor community continues to be very issue-driven, very supporting vertical programming. Ministries also tend to operate to a large extent along the same lines. So getting that narrative in is often very difficult. So I wonder what your thoughts are on how that can be more specific and be more operational in terms of an agenda forward.
Great. So I think we'll go back to the panel, and then maybe we'll have a chance for another round before we close. So the questions we've had are: do we have examples of where this has been done for disease outbreaks or other sorts of health threats where the cycle has been transcended? We have, how do we make this part of a continuum? So a similar question, how does this become a daily activity? How do people understand that it's not just something you respond to in crises? How do we understand that this really requires building a political movement, and how do we assemble that coalition, building on some nascent efforts, but what can we do more to ensure that happens, to bring us to the stage? And then two questions directed to Peter. One is, what about insurance? What's the role of insurance in financing preparedness and response efforts? And given that everyone talks about integration and two sides of the same coin, but what are the entry points really to bring this as part of an integrated global health agenda, given that donor financing in particular tends to still focus on single or specific issues? So I wondered whether perhaps Julie and Jimmy, you wanted to start with this. Are there examples where we've transcended this, and how do we make this part of day-to-day activity?
Rima mentioned, and apparently you discussed yesterday, the duality of seasonal flu versus pandemic preparedness, and that entire effort was designed to be dual purpose. As we know, we have seasonal threats every year, and what we do to better equip ourselves for seasonal flu will certainly serve us well in the time of pandemic. But I was thinking again about something Peter said about the role of business. I think the last time I saw Peter, we were on a panel at the World Economic Forum on preparedness, and I must say that all of the business leaders as well as other sector leaders who were there, our panel was singularly well under-attended. And it just speaks to the perspective that this isn't top of mind for most of the global leaders that were at least at Davos last year, or else they had something even more exciting to be doing. But I do think that business has a role. And when you have this problem of difficulty in focusing attention on something over the trough period, you have to take advantage of institutions and measures that you already have in place. And in businesses, I work for a publicly traded company. I'm on the board of another. We have to do risk assessment and risk mitigation and risk planning, and we have to disclose those risks as part of our mandated reporting. So, we have models and approaches to doing comprehensive risk assessment, which includes going out and querying people in our business and around our business to understand probability, impact, and potential for mitigation as part of that exercise. But when you bring something like this into that existing structure, you begin to think about continuity of business. And when you're in a health business, it becomes even more germane, because not only do you have to protect your own business, but you have to protect the people who depend on your vaccines and your medicines to protect them in the time of a health threat. So it becomes part of the planning process and the institutionalization of that inside a business environment. I think we could build on that. Most businesses go through a similar exercise, and when you put this on the radar screen, especially in the aftermath of a threat, because then it's top of mind, as Peter described in being in Hong Kong and Korea and West Africa, we may be able to strengthen the business participation, which is a component of building political will. So I think there is an opportunity here to step it up in the private sector a bit, and we have a couple of opportunities coming up where we may be able to work on that. And Steve, it's something that we could also take on in terms of the process that we're involved with from your organization. So I just put that out there as one example.
I'm happy to give a dilettante bureaucrat's perspective on the examples of threats and what we did well, I think, after anthrax and Ebola, and maybe some of the things that are really weaknesses there. I think that both were emergency appropriations, and almost by definition, that's the problem, that these are seen as emergencies, and that this isn't what Rima referred to as a continuum of funding and so on. The anthrax response, though, did create BARDA. You had Rick here yesterday, and I mean, this has really been a game changer, certainly institutionalized business government cooperation, the way we look at vaccines and Bruce's role and so on. So that, and created the Assistant Secretary for Preparedness and Response within HHS. So there are institutional advocates now for things that need to be done. And I think that in dealing with state and local governments and dealing with our international partners, these are really important institutions to have. There also was, when I was in Uganda, we suddenly had CDC people out investigating new countermeasures to plague. They had to find some very unique point in the world where plague was still a problem and investigate that. So we did use the anthrax platform to do other things. In Ebola, yes, the Global Health Security Agenda got feet, the financing these joint external evaluations, accelerating and getting WHO to take the lead in that so that these really were universal things. Dennis Carroll, I think, is here, and what he did on One Health, I think, is institutionalized now and has some legs. But the money ran out, and CDC has had to cut back on the people. Everything in CDC is program funded, and whereas the State Department and USAID have a career track of generalists who can be deployed from one thing to another. CDC does not have that, and the paradigm we're seeing in the world is people want our best experts to be able to help them with bring their own systems to first world capacity. CDC is our natural go-to partner for this, and they simply aren't structured to do that well. And I think that we need to address that as part of that continuum. And the only way to do that is through what Carolyn said. And she deserves a lot of personal credit, and PATH does, of trying to get at least the basics of a political coalition around health security. And $75 million, I mean, we really are debating tens of millions of dollars on a $1 trillion challenge, but at least we got the 75, and that, I think, is a start. We need, obviously, predictable, sustainable funding. And Peter, you're right about the SDGs. I just wanted to add this in encroaching a little bit on integrated global health agenda. But, you know, as at the end game of the SDGs, we had Ebola, and the health security, what did you call it, the single issue fundamentalists kept saying, we have 179 indicators, not one of them is about health security. And that's the case. So in a discussion like this, yes, we should be very conscious of the SDGs, and countries should be implementing those, but if you're looking at competing priorities for spending and what's being measured, health security ain't there, and I think that's one of our disadvantages.
Suzette, did you want perhaps to take the question on building a political movement? You already alluded
Sure.
to that in your intervention, both at the local level but influencing the national.
I would first start by saying that one of the most innovative things that I've seen at the local level in terms of what we can do or examples of things that are done well comes from my colleagues in New York City. And public health officials in New York City developed these documents that they call threat response guides. But they were literally one-page documents, front and back, that contained every bit of information that they needed to know to provide to their mayor and other elected officials that summarized the threat, the impact it could have on that city, and what they needed to be doing to avoid that impact. And so I think where we have real examples like that can be extrapolated to other elected officials to build the political will. You know, Jimmy, when you talk about, you know, the funding and things like that, those appropriations, whether they are emergency appropriations or standard appropriations, come about because of an act of Congress. So maybe we should build some threat response guides for members of Congress. Maybe we should get members of Congress engaged in some of these exercises. You know, this morning, the news is flooded with information about the situation in Bethesda yesterday, and there's a Maryland congressman who's very upset about what happened. So I think as we begin to see more examples like that, we should have greater opportunities to get congressional leaders involved. I think that, you know, when they are trying to pass a budget, issues like preparedness are often the first to go because they don't understand the impacts and the importance. And so that's what I think in terms of examples of how things are done well. And then one other example from a community perspective, my mind goes back to the residents in Joplin, Missouri, after the tornado there in 2011. You know, this idea of a coalition, but they really coalesced as a group of residents and community members to rebuild their city after that tornado. And I think where we can leverage coalitions like that to extend toward issues around outbreaks and pandemic preparedness would help us go a long way. And that, I think, speaks to the continuum piece as well. We need to build on lessons learned from previous events, whether those were in our own localities or even in other countries, and leverage systems that have been developed, perhaps for other things, that can help us sort of weather, if you will, some of the funding cuts that we continue to see.
And then to you, Peter, the two questions. One is about the role of insurance in preparedness and response. And then the second question is, what are the entry points in the global health sort of field, given that most of the financing instruments and donors are generally focused on specific issues, which often mitigate or make it more difficult to present an integrated agenda?
Okay, first on insurance. I think the role of insurance is both overstated with respect to countries and understated with respect to the private sector. Why is it over? Well, to start with, what is insurance for? Insurance does two things. One is it provides availability of cash to respond to an event after the event has happened. And second, it can create incentives for better preparedness if that investment is then reflected in lower premiums. The trouble is, when you think about it with respect to countries, and particularly the more vulnerable countries in the world, is actually if they have an event, the problem isn't the response cash. The problem is getting money for preparedness in the first place. So it's solving a problem, but it's not the big problem we face. Typically, we have found it much easier to get hold of money in response to a crisis than to prepare for one. Second, in terms of creating the right incentives, well, I'm afraid that doesn't really work because you're not going to get a sensible price for infectious disease risk in Guinea, Liberia, Sierra Leone, or whatever. And to the extent that any of this has been done, actually it's been paid for by donors. And so there is no incentive. And actually, I would argue the last thing we want is to get very poor countries to pay very expensive premiums for an insurance product when you could be spending that money on actually mitigating the risk. Because insurance in and of itself does not mitigate any risk. And they're not going to do that, not least because there are two factors about infectious disease outbreaks that mean the kind of economics of insurance work slightly difficult. One of them is that the externalities are large relative to the risk borne by the payer themselves. So much of the cost and threat of an infectious disease outbreak isn't borne by the country in which it first initiates. And second, because it's not a discrete event that you then have consequences of, like, say, an earthquake or a flood. It's an unfolding event. So defining the trigger is much more difficult. As a sort of point of information there, I would note that the only payouts that have happened from the World Bank's pandemic emergency facility have been from the component of the PEF that is not insurance driven, because the insurance triggers haven't been triggered. That said, I would like to see more infectious disease outbreak related insurance in the corporate sector. In most places in the world, it is simply unavailable. But if you had it available, A, it would be good for the companies to buy, and B, you would get the right incentives for them to get better prepared and for that to be reflected in their premiums. On the point of integration, and just to a small point of difference, indicator 3D of SDG 3, which is the Sustainable Development Goal for Health, is to strengthen the capacity of all countries, in particular developing countries, for early warning, risk reduction, and management of national and global health risks. So if one is taking a broad SDG agenda, one is taking that as one of the key indicators which we have to deliver against. And the significance of the Global Action Plan for SDG 3, which certainly all the multilaterals have signed up to, all the major multilaterals, is that we are saying that we're not just going to pursue our individual mandates, but we are going to work together to help countries, because ultimately it is countries and communities, but we are going to work together to help countries deliver on the SDG 3 agenda as a whole. Of course, we will lead on the bits that we are most focused on, and there's another indicator that's most relevant to me, which is around AIDS, TB, and malaria, but we're accepting that we need to sort of work together in a way that's more effective, because we need the whole thing to be pushed forward. To the point on the practicalities of this, well, there are a lot of really practical things we can be doing. So, for example, we're looking at how we can use, we're working with the Gates Foundation, for example, on emergency operation centers that for now are focused on malaria, but because they build an emergency management capability, could be multi-purposed to whatever stress or outbreak occurred. More generally, I am very keen to, I'd say, understand which of the sort of 48 component parts of the JEE map to the kinds of things that we and others are doing anyway. And we are doing a whole bunch of stuff. You know, Gavi is building cold chain distribution systems for vaccines. We are building disease surveillance systems. The disease surveillance system that's being used for the Ebola outbreak in DRC is the one that the Global Fund has paid for TB, HIV, and malaria. Also, the diagnostics, the gene expert machines are the ones that we put in place for TB. But at the moment, these things are not being done in a kind of full, and you know, that's us, we're as guilty of this as anybody. We're not doing it in a forward-looking, systematic way. We're not deliberately putting in things and capabilities and saying, we're doing this because we know it serves this purpose, plus it has the potential to do other things. And I think we could get more scientific about that. And one other thing, Rebecca Katz of Georgetown is helping us by doing a bit of mapping of some of the things that we would typically do in some of our programs and the 48 JE components. And I suspect there'll be some we tick off naturally, and some that if we did them 10% differently, we would do something that had much more utility from a health security point of view. And then there are some that are going to be really specific to health security. But if we can narrow it down to the ones that are really specific to a pure health security point of view, then we can have a much more focused ask. And we can concentrate achieving a lot of the other things through things that are good things to be doing anyway in pursuing the broader sort of health system development agenda.
So thanks to the panel for those questions. I mean, we're almost out of time. It's been a very sort of interesting and stimulating discussion, both from the panelists but also the contributions of participants in the room. I think to finish, the overriding impression I have from this discussion, I mean, I summarized some of the main points earlier, was the need to think of this in a big picture way and can reflect on what has gone well, but why we continue to really struggle to escape this cycle. In 1848, Rudolf Virchow famously said when he was testifying to the burghers of Upper Silesia during a typhus epidemic that medicine is a social science and politics is nothing but medicine writ large. And that was almost 200 years ago. And yet, when you listen to the discussions today, that challenge of taking our public health evidence, our science, but addressing psychology, behavioral economics, the incentives of people, emotion, the right brain, we still clearly struggle. Our panel seems unanimous that we can escape the cycle, that it is possible, but that it's very difficult. And that maybe then when we compare the difference between the approach to outbreak preparedness to other threats such as war or terrorism, and the difference in investments, the differences in the sustainability of those investments, maybe we just as a community need to reflect on that for all the success and the advancements over the last 100 years, we need to do a lot better. We need to tell our stories better. We need to make people feel it's relevant to them on a daily basis. We need to make them understand how it affects their daily lives and how it rates linked to the other challenges and threats that people contend with on a daily basis. And that is relevant to explaining and motivating people to engage in this endeavor in a village in Liberia, as it is to high-level policymakers and businessmen in Davos and in Geneva and in DC. Clearly, we do need to do better, because it is true that relatively low probability, high impact events like war or terrorism are funded continually, do succeed in getting that continuing investment. And maybe it's because, I mean, obviously there's a whole political economy that explains that, but maybe it's because people can relate. They have stories about war. They have stories about terrorism. Do they have stories about outbreaks? We've seen that during crises, we get these very vivid stories. I remember 2 years ago sitting in a village in Liberia and hearing these tales of heroism, of people who decided that they were going to act and didn't touch their children for 3 months because they were providing care for their fellow villagers. So there are these heroic stories, and Time magazine highlighted them in the aftermath of the Ebola epidemic. But yet we then quickly seem to forget them. They seem to disappear from the public consciousness in a way that stories of war, that stories of terrorism don't. So perhaps we should be proud of some of the achievements, but also a bit respectful and reflective of how we need this to do better. There seem to be real sort of shoots that we can build on. The institutions that have been built in the aftermath of the West African Ebola outbreak, the JEs, the Global Health Security Agenda, the institutions that have been built in the aftermath of all of our outbreaks, for example, the Health Act in New Zealand in 1920. So it is true that this may not be a straight line in terms of the effort. There will be times when we can intensify our efforts and build institutions. But we do clearly need to do business differently, and hopefully this workshop and this discussion is a tool and one step to take that end further forward. And I'm sure we'll continue the discussion for the rest of the day and throughout the rest of our careers. So I'll hand back to KG.
I think we have a few minutes for. Do you want to ask a question?
I was just trying to keep to the time, but
yeah,
sure,
yeah,
if
no,
I can.
Thank you. It's just yeah.
Before we close, if I can ask the panel one question. I think that if you look at public health over the last many years, since the last century or the last 2 centuries, we've approached much of public health as threat reduction. So we really public health focused on infectious diseases in the beginning, expanded to NCDs. But in that expansion, we have also made a fundamental shift. We've also begun to incorporate the idea of wellness. And so, for example, we focus on how do we build upon wellness as opposed to fighting diseases. And so, in a sense, how do we make better cities and so people can live better? How do we emphasize health systems? How do we, instead of just live longer, how do we live a healthy life longer? There is a shift in the discussion. If we look at climate control, there is an attempt, anyways, to not just emphasize how dangerous it is, but also to emphasize that you can develop a green economy and so on. So there is a big push to also change the dialogue to a certain extent. And I've often wondered if we are going to get off of this threat reduction approach, because regardless of what the real probabilities are, the concept for many people is that this is a faraway event. It is not relevant. This is true at the local level. It's true for businessmen. It's true for many of the sectors. And if we look at issues, Peter, like SDGs, moving from Geneva to Hong Kong is a very sophisticated community. But the SDGs is really a very abstract concept at that level. There are very few people who have heard about it, let alone fewer people who have incorporated that into any kind of systematic planning. It's a little bit bloodless. And then I think that we are also, in terms of donor funding and government funding, in an era in which much of the use of funding is to be catalytic. It is not really to sustain. Nobody wants to be left holding the bag for things, of which capacity building is an endless bag. And then the other issue is that we are also in an era, and particularly in this country, in which the whole approach to multilateralism is ambivalent. We talk about multilateralism, but we act differently in many respects and so on. So the issue, we either ride the horse of threat reduction and deal with all of those challenges somehow, and many of the suggestions have come up, or we also do take some kind of strategic change and we begin to say that that is not exactly the message we want to give, but in doing so, it also risks confusing everything. If you change the message, you are potentially going to undermine everything. And do you see a way of shifting that discussion and shifting the narrative, or do you think that it's really clarifying the narrative in a way which is believable or relevant?
Great. And seeing as we seem to have a bit more time, were there any other sort of final questions that anyone wanted to ask? Yeah, please.
Thank you. Mine's a comment, not a question. So my name is Pia McDonald from RTI International, and the punchline is pertinent to Julie Gerberding's comments about the private sector risk assessment and how much of that actually happens. So we recently did a study, a value at risk study, where we looked at the Fortune 500 companies in 4 different states to look at their disclosed international earnings and from what countries and industries those were derived. So rather than focus on the financial information, because that's actually very interesting in and of itself, I want to go to that risk assessment piece. So of the 43 firms in these 4 states, 27 had disclosed non-negligible levels of international sales. Nevertheless, only 13 of those, when we looked at the risk assessments in their 10K filings, actually disclosed any risks around disease outbreaks, public health issues, or anything associated with pandemics. So to Suzette and Peter's point, the need for education in the business community is significant. And my comment really just pertains to the need for that. So while in the health industry, the risk might be very well described, in other sectors, there's a lot of room for education. Thank you.
Hello, I'll try to make this short. My name is Avital Percher. I am a AAAS fellow placed at the National Science Foundation, and logically enough, my perspective is very technological in nature. And this has been a fascinating talk for me because it was some great insights into the considerations of structure and paradigms for approaches and so on, and how to handle outbreaks from an organizational perspective. But the question I have relates to the technological considerations. And one of the things that were discussed here was the blocks, the monetary, political, and organizational roadblocks that prohibit our ability to monitor infectious diseases and handle pandemic outbreaks. And I'm wondering what your thoughts were on the ability, what obstacles can be leapfrogged over with technological advances. Is that something that is on your radar in any capacity? Where can a technology that's developed in 10 years really catalyze our ability to handle a pandemic outbreak that is not currently available?
Can I take the last 2 questions? Or? Just one.
Good morning, and thanks for a really valuable panel. Monique Mansoura with the MITRE Corporation, formerly with BARDA and Novartis Vaccines. Dr. Gerberding, you mentioned many of the C's. A couple that I would ask for your comment on are countermeasures and corporate, sort of corporate from the perspective of those companies that develop medical countermeasures and this idea of panic and neglect from the perspective of what arguably is a long pole in the tent. I completely agree with Suzette. You know, the rubber hits the road at the local level. But when you look at Ebola 2014 versus 2018, the availability of vaccines is a very significant contributor to the response. And Dr. Gerberding, Merck and other companies have jumped in and responded, but many companies are now saying that this is not a sustainable business model for companies that make vaccines and other countermeasures. So if you could comment specifically on that issue.
So what I'll suggest we do is we just go across the panel, and if you could give a sort of short intervention on addressing some of those final round of comments, and then we'll close.
I think we could have a whole meeting on KG's question because it's a really, really important perspective, and a little bit of it also gets back to Peter's points about integrated, horizontal programs as opposed to vertical programs. For a period of time, I really tried to think about, the answer to the question, the United States spends the most on health, why aren't we the healthiest nation? And one of the things I realized is that we don't really measure health. Only recently, at a state and local level, are there indices that say what proportion of the population has none of the above. So we can say how many teenagers use opioids, or how many people have HIV infection, or how many people do this over here. But to say how many of our people are optimally well in our population is actually hard data to come by, because we don't really have systems that look at the integrated person. They're looking at their body parts or their diseases. So if you start doing that, and it is now much more common than it was when I was at CDC for those measures to be included in the state and local measurement tools, you start thinking about health as a natural resource in the same way that we think about our other natural resources, like our water and our clean air, et cetera. And it becomes a community good rather than an individual state, or in addition to being an individual state. And I think that's the kind of conversation that really leads to different kinds of investment and different kinds of thinking. If we could collectively look at our community health as an asset, as opposed to, you know, an on or off switch that individual people do or do not have, we might be able to come up with policies, you know, the health in all policies approach that would do probably more than having the best hospital in the community does for the overall health of the society. And I'll just jump to the last question about corporate engagement in vaccines. You know, Merck's experimental Ebola vaccine is being used in the DRC right now, and the journey from when it was tested by the WHO and others in West Africa to how it's being used today is a long and extremely tortuous journey. It has cost us far more than we will ever recover from BARDA or anyone else. We are certainly not looking at it as a commercial opportunity. Like J&J and Glaxo, who also stepped up to try to be part of the solution to Ebola, we did it because we could. It turns out that this particular vaccine that was developed in Canada and started on its journey to being a real vaccine by Newlinks, a small biopharmaceutical company, is grown in the same cell line that we used to make another common vaccine. So we had the technical capacity to do it faster than anyone would, starting from scratch. So because we had that capacity and we knew we could do it, we just did it. And I think that is not a sustainable solution. That's why CEPI is so important. I assume you talked about CEPI yesterday, but you know, having a global construct that allows us to move countermeasures to known threats forward, at the end of the day, they still will likely require partnership from existing companies because not too many people can bring them to the final state of approval and licensure that don't have the experience in that domain. But broadly, I think we should all be very concerned about the state of vaccines and vaccine technology on a global basis because we are experiencing shortages every day. Every company struggles with manufacturing these hard-to-make products. And the number of people doing it is shrinking, and the number of people interested in doing it is shrinking. So the market failure will become increasingly clear. And I think we have to think differently about how to move that into a more biodefense mentality as well. So it's a good question. I don't have answers, but I sure worry about it.
Sure, and a couple things. I agree, KG, great questions and complex framework. On catalytic funding, I think this is a huge problem. One of the things that the commission that Julie co-chairs and that she referred to, that Steve Morrison set up and I'm a part of on health security, CSIS, is to look at how this funding actually is sustainable, that we are really need to present this as a package. And just domestically in the U.S., there's 7 different appropriation subcommittees that need to get together if we're going to have a sustainable package to do this. And the idea that we're not just talking about centers of excellence or pilot programs or proof of concept, we actually need national scale. People have to do this at scale, and that is a different concept than many donors have faced. And your concern about multilateralism is one I completely share, and I think all of us in one way or another have referred to that. There really is some doubt based about whether norms and evidence and best practices are what should be guiding national or local decisions. And this has a couple forms. I mean, there's this, everyone I think in the Ebola response learned the French word réticence, the people who just didn't believe what the authorities were telling them in Guinea. And that was true in all, the politics of all 3 countries turned out to be very unfavorable to government credibility in the response. And we now have a kind of complacency because things actually are going pretty well in so many areas that the anti-vaxxer movement, the anti-vaccine movement is gaining strength with horrible consequences because people somehow think, well, my judgment's probably better than the authorities. And they're wrong, it's not. But we're living with that. And the technology leapfrogging, fascinating question. I'll just give one example. And you need to solve this problem for us, because during the Ebola outbreak, and in fact, I think earlier during the H1N1 outbreak, people who put in search terms in Google or other search engines about symptoms were remarkable predictors of where there were going to be outbreaks, and before the actual surveillance system get in. But as a policymaker, the HHS, you figure that's fascinating, but what do we do about this? How do we systematize that? How do we use social media both as an identifier of a problem and a response to those problems? And I don't think there are probably people here who are working on this and may have made progress, but I have to say that in our response, that got sort of neglected. Everyone thought that's interesting, but what are we going to do about that, or how do we incorporate that into our actual systems? And I don't think we've done that. So good challenge for us all.
Just briefly in response to KG's question, I think we are continuing to make more advancements in the areas of, health, wellness, first of all, but also health equity. And I would say, where those advancements and those promotions have worked well, those are some of the very systems that I think we need to leverage as best we can when it comes to outbreak preparedness. And to your question about the message and confusing the message, I think, clearly we don't want to confuse the message, but when we're having these discussions, we do need to help people understand how the failure to engage in proper pandemic preparedness could undo some of those very advancements that we've made in health and wellness, and create even greater disparities and inequities in health. So that would be what I would add to that discussion.
And finally, Peter.
First, to KG's question. On the SDGs, they are far from perfect. Although they mention health risks, for example, they don't mention AMR. But the reason I mention them is because if you want to understand the way that all the other major donors and the health multilaterals are thinking, they're thinking in the frame of the SDGs. But the main point about narrative that I would want to leave people with is the point about what happens when the narrative hits the ground in a poor, vulnerable country. The argument around health security, which is that you should invest in things that might kill you, and subtext, and even worse, might kill us, closed subtext, rather than the things that are killing you, is not going to work. It hasn't worked, and it's not going to work. And so we need to have a broader concept of health security that has more political and ethical legitimacy in the places where actually it is most relevant. Just quickly on the topic of innovations, there's no shortage of innovations I would like. If I would say areas that I think we are particularly needing good technologies on are one, diagnostics. Across the piece, diagnostics seem to be underinvested in, and yet the best thing to respond to any disease situation is a cheap point-of-field diagnostic, point-of-contact diagnostic that somebody relatively unskilled can use. So at least you know what problem you're dealing with. A second, really good geospatial mapping tools that you can use in resource-poor environments that allow you to get the very good as a basis for contact tracing and just incidents mapping, so you can target your interventions. And then third, and I realize this is a big ask, if we could work out how we can use modern communication technologies to build trust rather than undermine trust, that would be incredibly valuable. My big worry in the current environment is that in the most sophisticated societies, if we had a serious infectious disease outbreak, governments would find it very, very difficult to maintain a voice of authority and credibility in the way that communication works now. And I don't think we've cracked that problem.
So I think we all benefited from that coda. I think it raised a lot of further issues. Just to quickly then close, it seems that we probably do need to change the narrative, because the narrative we have, although it has delivered some successes, isn't giving us what we have. We can't convince even the health sector that this is something they should invest in significantly, because if we did, given that the health sector globally is $10 trillion, we should be able to find the money for these investments in preparedness, let alone in the frame of the SDGs, an indivisible and integrated agenda to really link to not just the health goal in SDGs, but all the other goals that also are needed for preparedness. So it does seem that we need to change the narrative, but at the same time, as KG said, we need to make sure that we don't undermine the existing progress that we've seen with some of the messaging that's worked. So I'd like to ask you just to join me in thanking our very insightful and esteemed panelists. And again, I hope that's provided a lot of fruitful material for our further discussions, and I'll hand back to KG just to tell us what the revised timeline is now as we go into the break.
So I'm the one who's responsible for getting us off track, but I don't think I can take away from a 15-minute coffee break. So meet at 11:05, please. So see everybody in a few minutes. Thank you.